So today in this lecture we are going to discuss few important questions from the section of INI-CET. So let us begin guys with the first question. A 34-year-old woman landed in Ames emergency after a road traffic accident with GCS of 3. She was intubated and sent for NCCT head, which was found to be normal. What is the likely diagnosis of the patient? So what do we have in the history? In the history we have that NCCT head of the patient is perfectly normal, right? The patient is an altered sensorium, right? Altered sensorium, and NCCT head of the patient is perfectly normal. So guys, there is one condition. There is one condition. In all cases of trauma, you must have read that NCCT head is the investigation of choice. But there is one condition in which NCCT head is not the investigation of choice, and that condition is diffuse axonal injury. For diffuse axonal injury, your MRI is the investigation of choice. And in these patients, what you are going to see, in these patients, you will see that in these patients the NCCT head will be perfectly normal. The patient will have history of RTA, and the patient will be in altered sensorium, non-improving sensorium, right? And what do we see on the MRI? On the MRI, in the SWI images, on the susceptibility weighted imaging, which is used to look for any calcification or hemorrhage, you will see multiple foci of blooming, okay, at the gray white matter junction, or you can see it in corpus callosum. So I will show you these blooming foci as we move ahead in the lecture, right? So trauma in CNS is a very important topic which you guys should study for this INI-CET exam, right? So what is the investigation of choice? Investigation of choice, we have already read that it is the NCCT head which is the investigation of choice in patients with head trauma. So how do we differentiate between NCCT head and MRI brain, right? Look at the bones, the bones appear white on CT images, and if you look at the MRI images, the bones will appear dark. So how to identify a bleed? On the NCCT? So just see that the bleed will appear hyperdense on CT images. The bleed will appear hyperdense on CT images, and based on the shape of the bleed, we can also guess what type of bleed it is. So if the shape of the bleed is biconvex, biconvex, then it is your extradural hemorrhage. That is due to the rupture of the middle meningeal artery. And remember, this was asked in your recent NEET PG exam also. Remember that the extradural hemorrhage will not cross the sutures. And if you look at the second image, the shape of this bleed is concavo-convex, and concavo-convex bleed is seen in subdural hemorrhage. And remember that it is due to the rupture of cortical bridging veins, right? It is due to the rupture of cortical bridging veins, and it is common in old age patients. It is common in chronic alcoholics, and this is an hemorrhagic contusion. The third image I am showing you, hemorrhagic contusion. So remember that an intraaxial bleed or bleed within the brain parenchyma, it will be surrounded by an area of hypodensity, which is your edema. So when an area of hypodensity is present, it means there is edema, there is intraparenchymal bleed. And guys, can you tell me what is the most common site? Okay, what is the most common site for hypertensive bleed? Can anyone tell me most common site for hypertensive bleed? In the comment section, hypertensive bleed. Anyone guys? Pneumothorax, Dr. Pihu, anyone who would like to answer most common site for the hypertensive bleed? That is your glutamen is the most common site, right? So we have seen that a biconvex bleed is your extradural hemorrhage, right? So we should know few important points about extradural hemorrhage. One is lucid interval. Lucid interval. So at the time of trauma, the patient is unconscious. The patient again regains consciousness and again loses his consciousness. This period of regaining of consciousness, this is known as lucid interval. Another thing that we are going to see in patients with extradural hemorrhage, that is your talk and die syndrome. Talk and die syndrome, right? The patients can die while talking because this is an arterial bleed. The size of the bleed is continuously increasing, and as the size of the bleed increases, you know, it is going to cause depression of the respiratory centers and the patient can die. So this is another very interesting image. Can anyone tell me what are we able to see in this image? So in this image we can see that there are two extraaxial biconvex shaped collections. But the point to note here is that these extraaxial collections, these are neither hyperdense, nor these are hypodense. But there is a mixture of hyperdense and hypodensities within these extraaxial collections. So if we look at these collections, you will see that in this extraaxial collection, there are few hyperdense areas. Few hyperdense areas can be seen. These are the hyperdense areas, and few hypodense areas can also be seen. Few hypodense areas can also be seen. So this means that hyperdense areas means that these are areas of acute bleed, and hypodense areas means that these are areas of chronic bleed. So whenever you are seeing hyperdense as well as hypodense areas in a extraaxial collection, so that will mean it will be a acute on chronic bleed, acute on chronic bleed. And looking at the shape of the bleed, so the shape of the bleed is concavo-convex, so it is a acute on chronic subdural hemorrhage, subdural hemorrhage, right? And another very important bleed, it is your subarachnoid hemorrhage. So subarachnoid hemorrhage, what you will see, you will see that there will be areas of hyperdensities. These are the areas of hyperdensities which can be seen along the basal cisterns. And what is the cause? Can anyone tell me what is the cause of subarachnoid hemorrhage? It is due to the rupture of berry aneurysm. It is due to the rupture of berry aneurysm, right? So this is your subarachnoid hemorrhage. You will see hyperdensities along the basal cisterns. You may see hyperdensities along the sulcal spaces. So what is the least useful investigation to confirm the diagnosis of the patient with the following condition? So first, let us see what is the condition that is being given to us. What is the condition that is being given to us? So guys, in this barium swallow image, we can see that there is diffuse dilatation of the esophagus and there is narrowing of the distal end, and this is giving a bird's beak appearance. And this bird's beak appearance, it is seen in achalasia cardia. So what happens in achalasia cardia? There is inability of the lower esophageal sphincter to relax. Inability of the lower esophageal sphincter to relax, right? So we are checking, we have to know the pressures in the lower esophageal sphincter. So here in this question we have been asked that which is the least useful investigation. So if we see that barium swallow will be a very important investigation, where you are going to get a bird's beak appearance, right? Then manometry again will be again a very useful investigation, which will help us tell the pressures in the lower esophageal sphincter. Upper GI endoscopy, again it will be useful, to take biopsies in the lower esophageal sphincter and make a diagnosis. 24-hour pH monitoring, this will be the least useful investigation as far as achalasia cardia is concerned. So now let us have a look at few important barium swallow images. So in the first barium swallow image, guys, what can we see? What can we see in the first barium swallow image? Anyone? Anyone in the comment section who would like to tell me? So we can see that there is a linear defect in the esophagus. So this patient again presented with dysphagia, iron deficiency anemia. So this is the case of esophageal web, in which we can see a linear filling defect in the esophagus. In the second case, the patient had history of acid ingestion, right? Acid ingestion. And what do we see? That there is smooth narrowing of the mid and distal esophagus. So this smooth narrowing in the mid and distal esophagus, this is seen in a case with esophageal stricture. Right? Now looking at the third image. What are we able to see in the third image? Anyone who would like to answer? So in the third image, guys, we can see that there is a diverticulum that is arising from the posterior aspect of the esophagus. A diverticulum is arising from the posterior aspect of the esophagus. The patient has history of bad smelling breath, and this diverticulum arising from the posterior aspect of the esophagus, this is known as Zenker's diverticulum. Right? So this is going to arise between two muscles, that is your cricopharyngeus and thyropharyngeus. Now looking at the fourth image, what are we able to see? In the fourth image, there is a diverticulum arising from the lateral aspect of the esophagus. So this diverticulum will arise from the lateral aspect of the esophagus. This is your Killian-Jamison diverticulum. Right? Now coming to another question. So this is your 34-year-old patient with pain in the left flank, presented to the OPD. CT scan was done and shown below. Identify the incorrect statement. So first, let us have a look at the CT scan. So what are we able to see on the CT scan? On the CT scan, we can see that there is a multiloculated cystic lesion. A multiloculated cystic lesion can be seen in the left kidney. So guys, whenever you are able to see a multiloculated cystic lesion, what is the first thing that should come to your mind? Multiloculated cystic lesion, whether you are able to see that lesion in the kidney or in the liver, what is the first thing that should come to your mind? It is your hydatid cyst of liver. should come to your mind, right? And what is the classification system that we use for hydrated cyst of liver? Hydrated cyst of liver, it is your Garby classification, right? So let us have a look at the options. Let us have a look at the options. So cyst content will cause hypersensitivity if leaked. Yes, this statement is true. Cyst contents can cause hypersensitivity. That is why FNAC is avoided. Okay, FNAC or aspiration is avoided. Okay, if it is in subcapsular location, because a rupture of the cyst can cause anaphylactic reaction, right? So FNAC should be done to confirm the diagnosis. Albendazole is given before performing nephrectomy. This is again a true statement. It's caused by a dog tapeworm. We all know it is caused by Echinococcus granulosa, right? So FNAC should be done to confirm the diagnosis. This is a wrong statement. Now coming to the next question, identify the name of the investigation. Identify the name of the investigation. Very simple question. And you also have to tell me what part okay is being shown to you in this image. What what ultrasound scan is being shown to you in this image? Anyone, guys? Let us see who is able to answer this. Anyone, guys? Anyone? So the name of the investigation that is being shown here, this is your ultrasound investigation. And what are being shown in this ultrasound investigation? We are being shown two lobes of the thyroid gland. Two lobes of the thyroid gland, right? And these are your carotid vessels. This is your common carotid artery, and this is again your common carotid artery. This is your ultrasound, right? So remember, ultrasound is a very important investigation. So let us discuss few important questions on the ultrasound. So can you tell me what is the name of the principle? What is the name of the principle on which ultrasound is based on? Okay, ultrasound is based on which principle? It is your piezoelectric effect. Piezoelectric effect, right? Piezoelectric effect. So can you tell me ultrasound is the investigation of choice for which important cases? For which important cases ultrasound is the investigation of choice? Remember, ultrasound is the investigation of choice in cholelithiasis, right? Your gallstones are very well visualized on the ultrasound. Remember that your fluid is a friend of ultrasound. Fluid is a friend of ultrasound. So if anywhere there is fluid within the body, whether it is ascites, right? Ascites, your ultrasound will be a better investigation. Whether there is pleural effusion, again your ultrasound will be a better modality, right? So this was all about ultrasound. Okay. Now, which of the following statement is true regarding corads? Right? So who will tell me? Who will tell me which of the following statement is true regarding corads? Corads zero is your normal lung. Is this statement true or false? Is this statement true or false? Anyone? Anyone? Is this statement true or false? So remember, there is nothing called CORADS 0. Okay, there is nothing called CORADS 0. So CORADS 1 is, CORADS 1 will stand for, CORADS 1 will stand for normal run, right? or or a non-infectious abnormality, right? Then another important point that you should know, CORADS 5, right? CORADS 5 will have features which are typical of COVID-19, right? Which CORADS 5 will have features which are typical of COVID-19 infection. And what is CORADS 6? What is CORADS 6? CORADS 6 is a PCR positive, PCR positive COVID-19 infection, PCR positive COVID-19 infection, right? And what are the important features? Important features of COVID-19 infection. So you will see ground glass opacities, in the periphery of the lung, right? So this is the most important finding that you are going to see in a patient with COVID-19 infection, right? So now coming to another question, a 65-year-old smoker male presented with nasal blockage and occasionally blood mixed nasal discharge with the following radiological and endoscopic findings. What is the likely diagnosis? What is the likely diagnosis? Esthesioneuroblastoma, inverted papilloma, JNA, maxillary sinus cancer. Maxillary sinus cancer. So let us have a look at this image. So guys, what are we able to see in this image? So this is a T2 weighted image. Why is this a T2 weighted image? Because we can see that the CSF is appearing bright. So this, what can we see in this T2 weighted image? There are hyperintense contents. Hyperintense contents can be seen in the left maxillary sinus as well as nasal cavity. Maxillary sinus as well as nasal cavity, right? And within this hyperintense contents, we can also see hypointense bands. Okay, hypointense bands can be seen, and these hypointense bands, these are giving the cerebro cerebro cerebr cerebriform pattern. Okay, and this cerebriform pattern, guys, this is characteristic of inverted papilloma. Cerebriform pattern is characteristic of inverted papilloma, right? As far as juvenile nasoangiofibroma is concerned, okay, it is a very vascular tumor, and we should know that this juvenile nasoangiofibroma, it is going to arise from phenopalatine foramen, right? And talking about olfactory esthesioneuroblastoma. So guys, we all know that olfactory esthesioneuroblastoma, it is going to arise from the olfactory nerves, and olfactory nerves, these are going to travel in the cribriform plate, olfactory nerves, right? So imagine a tumor which is arising from the cribriform plate. Okay, so if this is your cribriform plate and a tumor is arising from this cribriform plate, so this tumor, it is going to go upwards and it is going to go downwards. This tumor is going to go upwards as well as it is going to go downwards, right? So when it goes upwards, it can go upwards in the anterior cranial fossa, and it can go downwards into the anterior and middle ethmoid ear cell, right? and when it does so, it gives a dumbbell shaped appearance. Dumbbell shaped appearance. So just remember that this dumbbell shaped appearance, this is seen in olfactory esthesio neuroblastoma. Okay. Investigation of choice for localizing PTH, parathyroid adenoma. Very simple scan. Investigation of choice for localizing parathyroid adenoma. This is your cysta-MEB scan. Cysta-MEB scan. Right? So this is an image which is showing you cysta-MEB scan, and in this image you can see that there is increased uptake by the parathyroid, superior and inferior parathyroid glands, parathyroid gland, right? And what do we see on the ultrasound? Okay, on the ultrasound we will see a polar vessel sign, which is characteristic of parathyroid adenoma. So here in this ultrasound image, guys, what we can see that there is a hypoechoic lesion, and this hypoechoic lesion is supplied by a vessel, okay, which is giving this polar vessel sign of parathyroid adenoma. Now this is a very important question, okay, that has been asked in various exams like your NEET PG, INI-CET. Identify the MRI sequence. Okay, identify the MRI sequence. So this sequence is used in diffuse axonal injury. Okay, and the name of the sequence is susceptibility weighted imaging. So this susceptibility weighted imaging, it is used to look for any hemorrhage or any calcification. Or hemorrhage within the tumor, okay, within any structure, right? And these hemorrhagic and calcific foci, these appear as black spots, right? And these black spots, these are known as blooming foci, right? So in a patient with history of altered sensorium, right, then road traffic and accident and a normal city brain, you are going to see these blooming foci in the gray white matter junction in the corpus callosum, and this will be your case of diffuse axonal injury, right? Now let me just briefly summarize you all the sequences of the MRI brain. So the first sequence that I'm showing you is your T1 weighted image. So just remember, in the T1 weighted image, water is going to appear black, and there is one more sequence in which water is going to appear black, that is your flare image. Okay, in this image also water is going to appear black. Then you will have to have a look at the white matter. So if the white matter is white, this is your white matter. So if the white matter is white, then it is your T1 weighted image. And if the white matter is dark, okay, then it is your flare image, right? Now if you look at this image, second image, so in this image we can see that the sulcal spaces, these are appearing hyperintense because they have CSF within it, right? And because CSF is appearing bright here, it is a T2 weighted image. Mnemonic is very simple. World War II, water appears white on T2 weighted images. And what is the full form of flare? Fluid attenuation inversion recovery sequence. And in the third image, okay, it is again a T1 weighted image. Why? Because your water is appearing dark, your white matter is appearing bright, and you can also see enhancement along the meninges. You can see ring enhancing lesions. So this is a post contrast T1 weighted image. Post contrast one weighted image, right? So a 65-year-old male patient with history of atrial fibrillation presents to the casualty with right-sided hemiparesis and aphasia since 2 hours. So there is hemiparesis, right-sided. What you are going to think of? You are going to think of infarct, right? And aphasia since 2 hours, right? BP is 160 by 110, random blood sugar is normal, NCCT is normal, right? What will be your next step? So basically the examiner is just asking you, what is the investigation of choice in a patient with hyperacute infarct, right? In an infarct which is less than 6 hours old, right? In which NCCT head of the patient will be normal. So guys, what is the investigation of choice in a patient with hyperacute infarct? Anyone? What will be the investigation of choice? Sandesh, Dr. Pihu, Dr. Mithu. What will be the investigation of choice in a patient with hyperacute infarct? It will be your MRI, right? And within the MRI, the imaging features will appear as early as 30 minutes on diffusion weighted imaging, right? So this is a patient with history of left-sided hemiparesis. We can see that there are bright areas on diffusion weighted images, and on the corresponding ADC maps these areas are appearing dark, right? So these are your diffusion weighted images, and on the diffusion weighted images we can see hyperintense signal within the right temporal lobe, right? So this is a patient with a right MCA infarct, right? So let me tell you few important signs that you should know as far as hyperacute ischemic stroke is concerned on NCCT head. So you can see a thrombus, within the middle cerebral artery. So this is your dense MCA sign. You can see a hyperdense thrombus in the sylvian fissure. This is in the M2 segment of the middle cerebral artery. This is known as sylvian dot sign, and you can also see that there can be a thrombus can be present in the middle cerebral artery, basilar artery. So this is your dense basilar artery sign. So in this image we can see that there is loss of gray white matter differentiation, in the insular cortex. And this is again a very important sign that you can see in a patient with acute infarct, right? And this is known as loss of insular ribbon sign, right? And in this image, what we can see that on the right side, you can see this is your lentiform nucleus, this is your caudate nucleus, But on the left side you can see that caudate nucleus is not visualized, the lentiform nucleus is also not visualized, right? So this is another important feature that you can see in acute infarct on the NCCT head, and this is known as obscuration of the lentiform nucleus, obscuration of the lentiform nucleus, right? All these are important imaging findings in hyperacute and here in this patient we can see that there is a wedge shaped hypodensity that is involving the gray and white matter, wedge shaped hypodensity, right? And these are your important imaging features of acute infarct, right? Now moving to this question, 40-year-old lady presents with right upper quadrant pain. Ultrasound reveals multiple GB calculi with no wall thickening. So when the examiner is saying that there is no wall thickening, it means that there is no cholecystitis, right? So this upper quadrant abdominal pain, this is not due to cholecystitis. CBD is measures 12 mm. So guys, what is the normal caliber of CBD? Normal caliber of CBD is less than 6 mm, less than 6 mm. So it means that CBD is dilated in this case, right? And if you look at the various enzymes like your GGT, it is 5 times raised, ALP was high, and other parameters are normal. What is the next step? Very good question. So here we should know what we are suspecting. First we have to understand what we are suspecting in this case. So can anyone tell me what are we suspecting in this case? Even if you don't know, okay, what you are suspecting in this case, this is an MCQ. Look at the options. In the options we are given MRCP, ERCP, semi-urgent cholecystectomy, endoscopic ultrasound. These are the options. So can you tell me what are we suspecting in this case? Mohit, Sandesh. Okay, what are we suspecting in this case? So in this case, we are suspecting choledocholithiasis. What is choledocholithiasis? It is CBD stone. CBD stone. Right? Very good. Very good. Right? So when CBD stone can get stuck within this CBD, it can come from the gallbladder, as ultrasound has shown that there are multiple GB calculi. So this stone can stuck within the CBD and it can result in dilatation of the CBD as well as various enzymes like your GGT and ALP, right? So when the enzymes are raised, we are suspecting a CBD stone. What is the next investigation? What is the next step? Okay, we are going to confirm our findings, and the CBD stone is best diagnosed on MRCP, right? MRCP will confirm the findings of the CBD stone, and this will be our next step. So as far as ERCP is concerned, ERCP is both diagnostic as well as therapeutic. So ERCP, okay, it is done to remove the stone, as well as stunting is done using ERCP, right? Semi urgent cholecystectomy. Okay, so after CBD stunting is done, after CBD stone is removed, after that the patient can be planned for cholecystectomy, right? So this was all about choledocholithiasis. So can you tell me what is the investigation which is being shown in this image? What is the investigation which is being shown in this image? Anyone, guys? Which investigation is being shown to you in this image? Dr. Sandesh. So in this case we are shown an MRCP image, right? This is your MRCP image. These are your heavily T2 weighted images, right? Because these are T2 weighted images, okay? Your bile ducts, okay, common bile ducts, your left hepatic duct, your right hepatic duct, they are very well visualized on these MRCP images. And what do we see on this particular MRCP image? On this particular MRCP image we can see that there is a filling defect. There is a filling defect within the CBD, and this filling defect within the CBD is nothing but your CBD stone. This filling defect is your CBD stone. So let me show you another very interesting MRCP image. So in this MRCP image we can see that your common hepatic duct, it is dilated, right? Then we can see that this is your cystic duct, and within the cystic duct, guys, there is a hypo intense filling defect. There is a filling defect. All the stones within the biliary system, okay, they are going to appear as filling defects on the MRCP images, right? And this stone within the cystic duct, it is causing compression of the common hepatic duct, and this is resulting in dilatation of the same. And guys, this is seen in a patient with Mersey syndrome, right? So a stone within the cystic duct causes compression of the common hepatic duct and its upstream dilatation. So what are we able to see in this image? So in this image we can see that there is fusiform, there is saccular dilatation of the common hepatic duct. Saccular dilatation of the common hepatic duct. And this saccular dilatation of the common hepatic duct, this is seen in a patient with choledochal cyst. Right? Saccular dilatation of the common hepatic duct is seen in choledochal cyst, right? And what is the classification system that we used? That we use for choledochal cyst? This is your Rodani classification system. Right? So yes, now let us move to the next question. A 35-year-old patient presented with pain abdomen on post-op day 5 following laparoscopic cholecystectomy. Ultrasound shows a collection in the right upper quadrant. What is the next step? Okay, so you can see how the questions are changing in the INI-CET. Okay, they are not asking direct radiology questions, so you must be going to the wards and you should be knowing what is happening within the wards. Okay, so this is a very common scenario that happens in the surgical wards. So the patient comes to the radiology department. They give that the patient has a history of lap cholecystectomy 5 days back. Now there is fluid is coming. Okay, fluid is coming from the drain. Okay, what is the cause? What is the cause of collection in the right upper quadrant? Can anyone tell me what is the cause of collection in the right upper quadrant? Anyone? Dr. Kalyani, Dr. Sandesh? Very good. Okay, it is due to the bile duct injury, and bile duct injury can result in fluid collection in the right upper quadrant. So what is the next step? Okay, so whenever we have to image the biliary biliary radicals. Okay, investigation of choice, investigation of choice will be your MRC, MRCP, right? So MRCP will be done. That will be the next step. Okay, that will be the next step. We have to confirm. We have to confirm that the leakage of bile, it is from the bile duct engine, right? Then what is the best investigation? Okay, or the most sensitive investigation, that will be your HIDA scan. HIDA scan will be the most sensitive or the best investigation. Now a lot of questions are being asked on the PNS anatomy. Okay, identify the structure marked here. What is this structure? Okay, what is this structure that is marked here? This is your anterior ethmoidal air cell, right? This is your anterior ethmoidal air cell, right? So what are these? What are these two sinuses? What are these two sinuses which I have labeled as A? What are these two sinuses which I have labeled as A? Anyone? These are your maxillary sinuses. These structures labeled as A, these are your maxillary sinuses, right? Then two structures noted just above the orbit, two structures noted just above the orbit, these are your frontal sinuses. Frontal sinuses. We should be aware about the normal anatomy. These are your ethmoidal air cells, right? This bone that is connecting with the maxillary sinus, this is your inferior turbinate. Inferior turbinate, right? And another structure that you can see here, okay, that is coming from the roof of the nasal cavity, this is your middle turbinate. And here in this image, we can also see that there is pneumatization of the middle turbinate. There is pneumatization of the middle turbinate, right? So two important cells which I wanted to show you, okay, which can be asked in your INI-CET exam, which you guys can be asked to label in the INI-CET exam, right? So this cell, okay, which is seen inferiormedially to the orbit, remember this is your Heller cell. You must have read in the ENT, but they can show you a radiological image. A cell which is seen inferior-medial to the orbit, right? Then you can see a cell which is superior to the sphenoid sinus. A cell superior to the sphenoid sinus. This is the posterior most ethmoidal air cell. And guys, this is your ONOD cell. ONOD cell. So these two cells are very important, okay, which you should know. Identify the modality. So here in this image we can see that your bones, okay, bones are appearing white. You can see the soft tissues as well. So this is your CECT abdomen. This is your CECT abdomen which is being shown here. CECT abdomen which is being shown here, right? So what is happening in these images? So in these images we can also see these are your delayed scans, delayed contrast enhanced CT images, in which we can see that there is excretion of the iodinated contrast through the kidneys. Excretion of the iodinated contrast can be seen through the kidneys, right? So what is the likely diagnosis in this case? What is the likely diagnosis in this case? Right? So let us have a look at the options. Cystic hygroma, cystic hygroma, right? So cystic hygroma will appear as a neck swelling. In this region, we are going to see some cystic swelling. So this is not a cystic hygroma. Encephalocele, we are going to see some herniation of the brain tissue. There is no herniation of the brain tissue in this case. What is anencephaly? So anencephaly is absent of the brain parenchyma as well as skull vault. So here in this image, we can see that there is absence of part of brain as well as skull vault, right? So this is what you are going to see in the anencephaly. And what is the name of the appearance? What is the name of the appearance in anencephaly? The name of the appearance is frog eye appearance. Frog eye appearance is seen in anencephaly, right? So I will show you few more anomalies. In the first image, guys. In the first image, we can see that there is herniation of the abdominal contents through a defect in the abdominal wall, and these are surrounded by a membrane. So this is a case of omphalocoele. In gastroschisis, okay, the contents will not be bounded by any membrane. In the third image, we can see that there is fusion of the cerebral hemispheres. So this fusion of the cerebral hemispheres, this is seen in a case with holoprosencephaly. This is seen in patients with holoprosencephaly. Fusion of the cerebral hemispheres. Right? So this will be seen in cases with holoprosencephaly. And in the fourth image, guys, we can see that there is dilatation of the occipital horns, known as colpocephaly, dilatation of the occipital horns. And this is seen in a patient with CC corpus callosum agenesis. Two very important named signs. So here we can see that there is indentation of the frontal bones, right, and giving the lemon shaped appearance of the brain, of the skull. So this lemon shaped appearance, okay, of the skull. And in this image, we can see that your cerebellum, it is taking the shape of banana. So we have lemon shaped appearance and we have banana shaped appearance. So these are important imaging features of Arnold Chiari malformation. In which there is herniation of cerebellar tonsils. Right? So a young male smoker with intermittent pain in the calf on examination has a painful ulcer at the tip of great toe surrounded by blackened skin. Best initial investigation. Okay, so you have to understand what type of questions we are being asked. Okay, first of all, we have to make a diagnosis. So what is given to us? We have a history of smoking, then we have painful ulcer at the tip of great toe surrounded by blackened skin, right? So we are going to make a diagnosis of peripheral arterial disease. Right? So what peripheral arterial disease will be your diagnosis, and what will be the best initial investigation? Okay, so the first easily available investigation will be your Doppler ultrasound. Doppler ultrasound. And what are we going to see on the Doppler ultrasound images? We will see that there will be monophasic, okay, monophasic or loss of phasicity, okay, in the ATA, PTA and BP. There will be loss of phasicity in the lower limb arteries. Loss of phasicity will be seen in the lower limb arteries, right? So this will be the characteristic feature in patients with peripheral arterial disease on Doppler ultrasound. So whenever there are these long questions given in the main exam, never start reading these questions from the first line, okay? So start reading from below. What is the initial next line of management of the patient, right? So what are we shown in this x-ray? Okay, so have a look at this x-ray. We can see that there is a area of lucency in the right lung, okay, that is devoid of lung mark, that is devoid of lung marking. So this is a surgery and radiology question, right? So you have to identify that this is a case of pneumothorax. This is a case of pneumothorax, right? And the patient has history of road traffic accident, right? So the patient may be having some rib fractures also, right? On percussion, hyper resonant note is seen on the right side of the chest. Examination findings are given, okay. um, so what is the initial line of management, right? So you can read it in surgery. What is the next best step for a patient with pneumothorax, right? So what we are going to do, we are going to insert a large bore needle in the fifth intercostal space followed by an ICD, right? So this will be the next step that you are going to do in a patient with pneumothorax, right? So let us talk about radiology first, okay. Radiology. So in pneumothorax, what is going to happen? Okay, you will see a radiolucent area, that will be devoid of any lung markings, devoid of any lung markings. You should also know what are the ultrasound findings. On ultrasound findings, you will see that there will be a barcode sign. Barcode sign will be seen on M mode, imaging in a patient with pneumothorax. In a normal patient, on the lung ultrasound, what do you get? You get a C shore sign. C shore sign. Other very important sign of pneumothorax will be your deep sulcus sign. Deep sulcus sign, right? So these are few important signs which you should know as far as pneumothorax is concerned. Now this is again a question in which surgery and radio is combined, right? So the patient has history of peptic ulcer, abdominal pain and distension since 2 days. It gets worse since last 2 hours. Abdominal radiography is shown below. So what is to be done in this patient, right? So the patient's pp is on the lower side, okay. We are going to give IV fluids for the same, and now we have to identify what is being shown in this x-ray. So guys, if you are able to see, this free gas under the right dome of diaphragm, this is normally not visible, so if you are able to see this free gas under the right dome of diaphragm, it means that it is a case of, ये किसका केस है, न्यूमोपेरिटोनियम, right? So in pneumoperitoneum, what will be the treatment? Urgent exploratory laparotomy. okay, to look for the site of rupture, to site of rupture, and that site will be anastomosed and repeat. Okay. What other investigation you can do in pneumoperitoneum? NCCT. NCCT abdomen can be done. Okay, so just remember, investigation of choice for pneumoperitoneum will be your NCCT abdomen. NCCT abdomen will be the investigation of choice. ठीक है, so we are left with two more questions. The radiograph shown below is done for better assessment of the frontal sinus. What is the common name of this view? The name of this view is Caldwell view, right? So, okay, in Caldwell view, it is done to better visualize your frontal sinus. And if we talk about Waters view, this is done to better visualize your maxillary sinus. And if we talk about Stenver's view, this is done to better visualize your petrous part of temporal bone. Right? So the most important are your Caldwell view and your Waters view, which you guys should remember. Right? So which area is evaluated along with abdomen during E-fast? So remember that in E-fast you are going to evaluate your thorax, okay, your thorax, to look for any pleural effusion, or pneumothorax in a patient with trauma, in a patient with history of, right? So guys, this was all for today's class. We have other lectures coming on this MedEd YouTube channel for INI-CET discussion. So these channels, okay, you can look at the schedule and you can stay tuned on this channel, and this will help you in your INI-CET preparation. So bye bye guys, take care, keep working hard.